So I wanted to present a case and a paper, both of which have caused a fair amount of grief during my fellowship, and get feedback and hopefully a good discussion. Oh, I'm used to a Mac this way. Okay. So basically, objectives are to discuss and get help with a confounding case that I saw early in my fellowship about perimenopausal woman with multiple fractures, and then discuss a paper that I was exposed to during fellowship that I'd really like input in knowing how to use those findings in dealing with individual patient data. So here's the case, and I'm going to go through it quickly because limited time, but she's a woman I met in December 2014, so 6 months into fellowship, 55-year-old woman presenting for evaluation of multiple fractures. She had a normal childhood, normal development and activity, no dental issues, no childhood fractures. At the age of 43 in 2004, she developed severe osteoarthritis of a right knee, she thought due to a prior motor vehicle accident, and she underwent a partial right knee replacement. In 2005, so at the age of 44, she's still menstruating. She had a right olecranon fracture after a fall onto ice, no evaluation thereafter. And then in June of 2006, at the age of 45, she was getting into her car and said that she just felt intense pain in her right hip, and she was diagnosed with a hip fracture and underwent surgical repair. And I don't have the specifics of the, it was a femoral neck fracture. I don't have the specifics or the image of that fracture. But she was started on Fosamax therapy for presumed osteoporosis, and I don't have the images of her bone density, but I do know that it was done on a lunar machine, and those are her T-scores. So at the wrist, a T-score of minus 0.9. At the spine, and she did have scoliosis, a T-score of plus 0.8. At the hip, minus 0.8, and at the neck of the opposite hip, the left hip, obviously, minus 1.2. So, and her urinary NTX from July of 2006, so 1 month after her fracture, and it was obtained at 1:30 in the afternoon, so we're assuming she ate, but it was only 20 with a reference range of 5 to 65. She describes getting rib fractures after hugging people at a funeral in July of 2006. In August, so just 2 months after her original fracture, she had right femoral pain, and she was diagnosed with a stress fracture near the site of her hip fracture repair, and she had to get a rod placed. She continued on Fosamax for 2 years. In August of 2008, she had left thigh pain and was diagnosed with an atypical femur fracture, and during repair of that fracture, she was discovered to have a crack in her femoral neck on the left, and so she's basically left with bilateral intramedullary femur rods and dynamic hip screws. And so I met her in this, and there's a picture later on, but there they are. And I don't know if we want to comment, but her bones just look awfully thin and maybe even a little raggedy. But those were recent x-rays. So then in June of 2014, she was stepping down off of her porch and suffered an acute left tibial fracture, which was repaired with a rod that of course got infected and was a big issue. And I met her 6 months later in December to say help. So here is the picture of her left tibial fracture. And they don't this is the impression from the radiologist. They don't comment, but it looks beaked. It's transverse. I don't know whether these are thickened cortices. And I should say that, make clear that she was on Fosamax from 2006 to 2008. When she was diagnosed with the atypical femoral fracture in 2008, she stopped Fosamax. Here are her labs that I got when I saw her in December. So normal CBC, creatinine was normal, her GFR was 60, normal LFTs, a normal immunofixation. Her ALK phos was slightly above normal right after her fractures. It ranged from 100 to 130. You can see her calcium, her phosphorus, her albumin, normal thyroid. Her PTHR assay goes up to 65, is 51. Oh. She'd always had normal vitamin D levels. She'd had multiple celiac antibodies, and her total IgA level, which is not on here, was normal. And she was on hydrochlorothiazide, so she had a low 24-hour urine calcium. And just point out that her 24-hour urine cortisol was on the lowish end of normal, and I'll go over what kind of steroids she had gotten. And her urinary NTX in December, so in the middle of getting rods replaced for the infection, was 69. Milligrams per 24 hours? So 20 milligrams per 24 hours. Yeah. Yeah, on hydrochlorothiazide. Yeah, it's low. And she'd had a couple others. She'd had one that was 40 and one that was 70 prior to this. In January, so I saw her in December, got that workup, and then in the intervening time, she was recovering from her fracture, and she was temporarily out of her boot and took a step forward and suffered further tibial fractures. And then in September, she actually hyperextended her right knee and got a patellar pop and a fracture, and I have those pictures. And so you can see that here's the new fracture, here's the recovering old fracture, and then these lucencies, and they comment on this vertical lucency here, which is a fracture. And then here's the picture of her patella, which you can see the fracture through there. And I should point out also that with all of these, there was never any external bruising to have suggested trauma. So just bone-relevant history. She had gotten steroid injections. In 2004, when she was dealing with her osteoarthritis, she'd gotten them into her right knee. She'd gotten into her spine for spinal stenosis in 2013, and then into both shoulders in 2014. But there was never any prolonged oral courses of chronic high-dose steroids, just some brief intermittent ones. She had menarche at 14, natural menopause at 2006, and then she actually was started on hormone replacement therapy. No bone-averse medications. She does have a history of inflammatory polyarthritis. She's on Plaquenil. She's never been on chronic steroids for that. Her mom had a hip fracture. She says she used to drink alcohol. She was very hesitant to say how much, but she does not drink alcohol now. Okay, and then again, given time, I'm not going to go further into this, but she does have bad osteoarthritis, recurrent bladder prolapse, and she had a partial colectomy for an atonic colon. I just point those out just in terms of collagen issues. All right, physical exam, the most important thing is that she was short. She thought she's lost 1.5 inches, but for her mid-parental height, mom was 5'6", dad 5'8", she was only 5'1". And possible mild dolichocephaly, my attending pointed that out, where I thought maybe her head was longer than wide. So here's her bone density when I saw her. That's her spine. I don't know why they left off L1. That looks like the best one to interpret to me, but obviously she has a lot of arthritis there, and her T-scores are elevated because of that. And here's her one-third radius, which you can see the T-score is 0.2. So, and here's her thoracic spine film, which actually looks pretty good. It was read as no compression fractures. So, in summary, a 55-year-old woman, multiple fractures, perimenopausal, some steroid injections, and an inflammatory arthritis, but no other identifiable risk factors. She seems to have suffered cortical bone fractures, and yet her one-third radius bone mineral density is normal. So, what is the next best modality to evaluate her obvious poor bone quality? And it gets to the idea of what is the accuracy of DEXA. Now, I understand that, it's not all in the density, but it does raise, it kind of goes on to this other paper that I was exposed to during residency that I'd like help understanding. So, disclaimer, I'm not professing to espouse the following study claims. I've been exposed to this during fellowship, and I found it completely confounding, and I'm taking this incredible opportunity to discuss it with leaders in the field. Okay, so this is the paper. It was published in JBMR in 2001 by Bolton, and inaccuracies inherent in DEXA. And he is from Australia, and the co-author is from Finland. And when you put him into PubMed, he has about 12 or 13 articles. These are just some of the recent ones, but he's published a fair amount on, on this issue in different journals: JBMR, Bone, International Osteoporosis.
By the way, I've never heard of him.
I understand.
This is a comment. I've never heard of him.
Yep.
I've never seen him. I don't think I've ever heard him present a paper.
Yep.
This is a comment.
Yes, I understand. So his basic tenet is that we all know that DEXA, we use it to evaluate the propensity for fracture. He says that studies have shown DEXA-derived in vivo bone mineral density to be subject to sizable inherent inaccuracies that may adversely influence our measurement outcomes and therefore our ability to predict bone fracture. And he uses cadaveric studies, phantom studies, simulation studies, and quantitative analysis to support his claims, and we'll go into some of those. And collectively, these observations and results may be seen to constitute a formidable case for a reevaluation of the reliability. So I'm just going to say, why does he think they're inaccurate? Like, what's his basic beef with DEXA? And he basically says it is a two-component DEXA limitation. So there's two energy things like Compton scatter and photoelectric scatter, and they are designed to only measure 2 components. And when you try and measure something with more than 2 components, it's going to be inaccurate. And bone has 4 separate components. So you have the bone, the bone marrow, the extraosseous lean muscle, and extraosseous fat. 4 separate components, and he's saying that DEXA can't reliably differentiate all of those. In addition, he feels like the bone marrow itself is composed of red and yellow marrow that is very much in flux and leads to further inaccuracies. So I just want to go into the evidence. I'm not going to go into all of these. I'm going to focus on the phantom studies and the cadaveric studies. So and I pulled these papers, and these were based on other people's data. So basically, phantom DEXA studies are taking realistic models that have the same absorptiometric properties as all the materials found physiologically, and then subjecting them to DEXA. So basically materials specially formulated to span all the ranges of bone marrow density in the marrow, the bone, and external to the bone. And basically saying that they were matched virtually exactly. And then he subjected them to DEXA by Norland, Lunar, and Hologic. And so these are confusing, but let me walk you through them. So this is just the Hologic machine, but they look the same on all the different machines. This is the inaccuracy, so it's either inaccurate underestimating or overestimating. And this based upon the fraction of marrow that is yellow. So it's either all yellow marrow or all red marrow. And then the different 1, 2, 3, 4 is based on different fat to lean mass. So they kind of did these with different external things. And the different lines are different sizes of the bone that he used. So he's basically saying that for different concentrations, you can underestimate it by 60% or overestimate it by 20%, and it differs based on whether your extraosseous material is the fat to lean ratio of those. Everybody understand with me? Confusing? Okay. So a lot of words, basically just saying that all those components really affect the DEXA outcomes. It's a lot of words, but that's basically what he was saying. So I know, in interest of time, I'm just going to go quickly in the cadaveric studies pulled this paper. And basically the background concepts, again, are that they were focusing more on the marrow and how the marrow affects the outcomes. And so they basically took 19 cleaned cadavers, so they're getting rid of the extraosseous material, and they're just looking at the effect of the marrow. And they took the bone, they sliced it into 20 millimeter thick slices, they weighed it, and they did a DEXA on it, and then they took out the bone marrow, so they defatted it for 2 weeks, they weighed it, and they did a DEXA on it, so it's just a DEXA without the internal marrow, and then they decalcified it and got the weight so that they could get the amount of mineral weight by decalcifying it, comparing the weights. And a lot of numbers just focus on this. So if you look at the bone mineral content by weight, which is taken to be the kind of gold, exactly what the bone marrow mineral weight was, and you look at the first DEXA before defatting and the second DEXA, you can see that they underestimate the true bone mineral content, and that the higher the fat marrow content was, the more it underestimates the true bone mineral content here. See that? So his thing was that underestimated chemically determined bone marrow content, that it was not a constant value, the accuracy error, and that there was variation in fat that influenced DEXA, and that you can't predict it. You can't predict somebody's marrow to know how it's going to affect the DEXA. And then last cadaver study was 14 cadavers that they did in situ. So they took the cadaver before taking the bone out, and they did the DEXA, then they took the bone out, and they put it in water so that there wasn't all the extraosseous stuff, and they did the DEXA that way. And this is the last graph. Basically, this is looking at the 32 vertebra and saying that when they did it in vivo, so before they took the bones out of the cadaver versus in vitro in the water bath, to read the graph. So three had a negative up to 5% difference. 9 had an up to a 5% positive difference, and you can kind of go through. So one of the studies had an up to 20 to 25% difference, negative difference, between the two DEXA scans. So conclusions being patient-specific DEXA measures in vivo can readily exceed 20% or more. And this was by a different paper, Blake and Fogelman. They're out of England, out of the UK. Sorry, stop. And he was just, this is my last slide, a graphic representation of here's the patient's point density, here is the precision, the confidence interval when you take into account precision errors, which is very little, as we know, it's pretty precise. But if you build in accuracy errors, here's the confidence interval for accuracy errors. So again, I'm not professing to say this, I just was exposed to this. I found it difficult to see this data, which he kind of, I feel like he drew from a lot of different sources, and then when I see a patient in my clinic and they come with a bone density of a t-score of -3, but they have no other risk factors, et cetera, how do I, with this in mind, how do I interpret that? So regarding conclusions regarding my patient, the paper presented, you tell me, but regarding the preceptorial, it was fantastic. So.
Well, we could spend the next 2 hours.
I know.
talking about